I'm Dr. Pedro Ramirez, and I am the chair of the Department of Obstetrics and Gynecology here at Houston Methodist. I am also a gynecologic oncologist. And today I have the pleasure of having with me on the studio Dr. Pedro T, Dr. Jessica Floyd, and Dr. Carolina Kilowski. We're really excited to be here to talk about the topic of de-escalation in the management of patients with gynecological cancers. We're going to focus on the three main gynecologic cancers: cervical cancer, uterine cancer, and ovarian cancer. But before we do that, I would like to introduce and have them introduce themselves, each of my colleagues, and talk a little bit about where you practice and the types of patients that you see.
Yeah, my name is Dr. Pedro T. I'm a GYN oncologist at Houston Methodist Willowbrook. I see all sorts of GYN cancer patients, and yeah, it's really great to be here. Thank you.
Yeah, thanks so much. I'm Dr. Jessica Floyd. I work here at Houston Methodist in the medical center. I also see the breadth of gynecologic cancer patients, and thanks so much for having us, Pedro.
Yes, thank you. I'm Dr. Carolina Kilowski, and I'm at Houston Methodist, the Woodlands Hospital, and it's an honor to be here today. I think this is a great topic of discussion, and just like my colleagues, I see a variety of patients every day, and I'm excited to talk about them today.
Excellent. So thank you so much. And as I mentioned, there have been great advances in the field of gynecologic cancers over the last 10 years or so. But one of the things that we would like to focus on today is the concept of de-escalation. And certainly for many years, gynecologic cancers were treated with very aggressive surgeries that were often associated with major complications, prolonged length of stay, and a lengthy recovery. Similarly, again, we had very limited options in the past as it pertains to treatments with chemotherapy or radiation therapy. And now, of course, obviously, there's quite a number of targeted therapies that we use for patients with gynecological cancers. So I wanted to just first ask each of you, how do you see the concept of de-escalation in the treatment of patients with either cervical cancer, uterine, or ovarian cancer? And I'll start with you, Pedro.
Well, I think it's we're certainly seeing a lot of de-escalation, and I think the concept that I like to think about is that we've really evolved from where we're giving a lot of treatment, kind of in a sledgehammer style, to more of a precision and molecular-based type of treatments, and we've gotten a lot smarter. So at the same time, because of this precision, and we are de-escalating, but in some instances we're actually escalating. Like in endometrial cancer in advanced stages, we're adding immunotherapy for some of our patients. So yes, we are definitely seeing a lot of de-escalation, but we're also seeing some escalation. I think we're just getting smarter about how we treat these cancers.
Excellent. So I'll turn to you, Jessica. How do you see the concept of de-escalation, and how does it impact the care of your patients on a daily practice?
Yeah, I think as a specialty, we've been inspired to seek strategies to de-escalate based on patient experiences, whether it's somebody who wants to preserve their fertility or someone that we see recovering from a really challenging surgery, or using a therapy in someone and wondering, is this really helping them? And so I think we've been really thoughtful about asking some of those questions through clinical trials and other outcomes data, and that comes into the day-to-day of being able to counsel patients on, this is what we know about this treatment for you, instead of just, this is the treatment that we use for everyone.
Yeah. And Carolina, I was wondering if you could focus more on the younger patient population, and particularly, obviously, gynecologic cancers also impact that patient population. And we'll talk a little bit more about fertility and fertility preservation, but I was wondering if you could just give us an introduction as to how de-escalation of treatment impacts the fertility preservation in many of our young patients.
Yeah, I really liked the paper that was recently published, the retrospective cohort study looking from 2004 to 2020. They reviewed thousands of patients, I think almost 1 million in all 4 cancers that we commonly treat. And when it comes to fertility sparing surgeries, minimally invasive surgeries, all of those numbers have increased. And I think de-escalation is real, and it is happening, and it's the forefront of our care. And it's really important to address it, make sure that we're doing it with, high evidence-based data, before we agree that this should be the standard of care, in order to not, restrain patients from getting the best oncological outcomes. So that applies definitely when it comes to fertility preservation. We are seeing women, unfortunately, develop, especially endometrial cancers at a younger age, younger than 40, and we want to do everything we possibly can that's safe to preserve their fertility.
Yeah. So let's talk a little bit about the GYN cancers that we see. Most commonly, typically, is endometrial cancer, ovarian cancer, and then third, cervical cancer. So I'll turn to you, Beirut, and talk a little bit about endometrial cancer. We'll subsequently talk about the de-escalation, but perhaps you can share with our audience how frequent is endometrial cancer and what are some of the risk factors?
Yeah. So endometrial cancer happens to be the most common gynecological cancer in developed countries. I think when we're looking at developing countries, cervical cancer is still the top cancer in those countries. But here and other developed countries, it's endometrial cancers. And, the reasons are pretty much based on, kind of what I call first world problems. It's due to, biggest risk factor is obesity. So that is a big driver of the endometrial cancer epidemic that we're seeing. We're really seeing a significant rise in these cancers that even when we're looking at the mortality, it's catching up to ovarian cancer.
Absolutely. So let's talk a little bit about de-escalation in endometrial cancer. And certainly, again, we will refer to endometrial uterine cancer routinely throughout the discussion. But of course, obviously, they're the same. So for patients with uterine cancer, for a long time, patients required, of course, obviously, a hysterectomy, removal of the tubes and ovaries, and assessment of the staging or the spread of that cancer to the lymph nodes. This was done through an open surgery that required long and recovery, prolonged hospitalization. What's the standard today?
So it's been, an evolution in the past few decades of de-escalation in endometrial cancer. We went from open surgeries where surgical trials showed that minimally invasive surgery is safer with equivalent oncological outcomes. We used to pretty much strip the entire lymph nodes in the pelvis and the lower abdomen. And to get, the staging of the patients. And the downside from that was, a lot of these patients would end up with very painful chronic lymphedema. And this was a lifelong condition that they would suffer from. And so we moved and de-escalated, largely because of the FIRES trial, to a Sentinel lymph node, where we're basically just removing primary lymph nodes in the pelvis, and with high predictive accuracy, and that's significantly reduced the complications that arise compared to complete lymphadenectomy. So those are some of the de-escalations that we're seeing. We're also now offering fertility sparing for endometrial cancer patients. So like Caroline was saying, a lot of these patients are showing up younger than in their less than 40s. And so, the NCCN guidelines have, a pretty good strict criteria, for these patients who have a grade 1 cancer, who have no myometrial invasion, and on their imaging don't have any evidence of extrauterine disease and no evidence of deep invasion, that they're eligible for hormonal treatment, either using a pill like Megace or a Mirena IUD, in order to preserve their uterus so they can have that complete response and eventually go on to have a successful pregnancy.
Great. So thank you for that excellent overview of the de-escalation in endometrial cancer. And staying on the topic of endometrial cancer, Jessica, I'll ask you, as it pertains to the surgical approach, and obviously, as I mentioned in the past, long, big incisions in the abdomen. Is it a standard today to perform a laparoscopy or robotic surgery? And most importantly, I think for patients, are we compromising oncologic outcomes by performing minimally invasive surgery?
Yeah, I think it is standard in endometrial cancer, or it is standard in endometrial cancer to do minimally invasive surgery for nearly all patients. Obviously, there's some caveats to that, but we have randomized clinical trial data showing us that it's safe oncologically, and patients have less surgical morbidity from a laparoscopic surgery. I mean, now we're sending these patients home the same day. You see them 2 weeks later, they don't look like they've even had surgery. It's really phenomenal, the progress that's been made with doing minimally invasive surgery. So it's absolutely the standard, and we should feel comfortable doing it with the data that we have.
And what would you say are the greatest advantages to the patient from doing a minimally invasive surgery, laparoscopy, or robotics?
Well, I think there's a couple of things. One is just the recovery. There's no hospital stay. I mostly see patients feeling like themselves much sooner than when they have a laparotomy. And if this is a patient who we find out does have metastatic disease and it needs to get to treatment, now we don't have a big incision that has to heal before we can get there. So that expedited getting to treatment sooner after surgery is an important part of it also.
And staying on the topic of the surgical approach, is there a difference between laparoscopy and robotic surgery?
I think that's just surgeon preference in terms of, what you do the most of. I know it seems a lot of people are moving toward robotics. I trained at a program that was about 50-50, so have a little bit of a deep-seated love for straight stick surgery, but I think it's just surgeon preference.
Excellent. Carolina, I'll ask you, Beirut's mentioned the concept of sentinel lymph node mapping, and of course, obviously, it is an approach for staging that is now routinely performed for many disease sites in oncology, but focusing on endometrial cancer, is it a standard today? And what are the advantages to the surgeon in terms of the information that they receive from sentinel lymph node mapping, and also advantages to the patient?
Yeah, so we also have data and clinical trials showing that sentinel lymph node mapping does have very high detection rates, negative predictive values, that we can rely on them with proper technique, and making sure you have access to ultra staging at the pathology department, because that is required to detect, ITCs and micrometastasis. So the technology needs to be there, the training needs to be there, but if that is all in play, then yes, there's a huge advantage from a surgical perspective, the amount of time required, post-operative complications to the patient, any neurological or infectious, standpoint, lymphedema. So, lots of advantages there using sentinel lymph node mapping.
Yeah, I think, the Endo study was a pretty important study highlighting why ultrastaging is important, because, even in low-risk patients, they found 10% of patients had evidence of metastatic disease from ultrastaging. So I think that's very important. If you are doing sentinel lymph node mapping and removing these lymph nodes, to make sure that your pathologists are doing ultrastaging.
And then the key, of course, proceeding with a full lymphadenectomy. If it fails, it does fail a small percentage of time, but, just kind of addressing that and making sure that's the protocol.
And then in terms of the technique, for our patients, often they will ask about, what are you going to do in that setting? Can you talk a little bit about what is actually done when performing sentinel lymph node mapping? Does it bring any additional risks to the patients?
So it's a very low risk procedure. At the beginning of the case, we discussed that we, visualize the entire cervical tissue and we inject, either ICG, the blue dye, and then that is something that we can appreciate on Firefly during the robotic surgery. And the dye travels through the sentinel lymph node pathway to the most dominant lymph node in the pelvis bilaterally. And those are the lymph nodes that should be dissected and removed and sent for ultra staging. So, in my opinion, It's a very low risk procedure, low complication risk, no risk of, potential allergic reactions. Like some patients worry, they have an allergy to certain contrasts. That's, not the case. So very, very safe profile there.
Yeah, and I think it's also important to convey the message that sentinel lymph node mapping in endometrial cancer is not an experimental procedure. This is part of our standard everyday practice.
Right. It's the preferred method based on the NCCN guidelines.
Mm-hmm. Yeah. Excellent. So we went, and the topic of de-escalation, we went from full lymphadenectomy, removal of all of the lymph nodes, prolonged procedure, high risk, to sentinel lymph node mapping, where we just identify one lymph node on one side, another lymph node on the other, and that provides us adequate staging, perhaps some would argue even better staging than the full lymph node removal. But now the question that is coming up is, do we even need to perform a sentinel lymph node assessment? So to that point, I'll turn to you, Beirut.
Right.
You're leading an important study that is an international study, and I believe Houston Methodist is the only site to date that has a study open in the United States. It's called the ENDO-3. Can you tell us a little bit more?
So ENDO-3 trial is a randomized phase 3 international trial where patients with uterine confined endometrial cancer, and so these are patients who, to be eligible for the trial, have to have imaging showing no evidence of extrauterine disease, are eligible for the study. And basically in the study, the patients are randomized to sentinel lymph node mapping versus no retroperitoneal node dissection. And the concept of this study really came based on a lot of randomized trials that were done in Europe many, many years ago, like the Astra study that showed that lymphadenectomy did not affect outcomes. It was certainly diagnostic, but versus patients who had lymphadenectomy versus those who didn't have any difference in their outcomes based on the treatment that they received in the surgery. So this trial gives the patients an opportunity to undergo surgery without removing lymph nodes, which would decrease their operative time, even though, like Dr. Kolowski said, it is minimal, but it is still, it does increase operative time slightly. And you are still dissecting around major blood vessels, right? And so that risk is still there of injuring a major blood vessel during this procedure. And so that trial is really going to look into long-term outcomes as well. So we have patient-reported outcomes that we're going to look into, because this is something that's kind of unknown about sentinel lymph node and endometrial cancer. What are the effects specifically on lymphedema and what the quality of life on these patients who get sentinel lymph node versus those who don't. And we'll also obviously look at oncological outcomes too, and we'll see what the data shows.
Excellent. No, thank you for leading that study here. So again, we've covered surgical approach. Mm-hmm. We've covered the de-escalation to sentinel lymph node mapping. I'll turn to you, Jess, and let's talk a little bit more about molecular profiling. And tell us a little bit about what is that and how are we using it today in the management of patients with endometrial cancer?
Yeah, I think endometrial cancer, we've come a long way recently, especially with characterizing tumors as mismatch repair proficient or deficient, whether they have a POLE mutation, whether they don't have an actionable mutation. And that helps us make treatment decisions. I mean, a lot of the agents that we have coming out that we can use in endometrial cancer, we're studying them in the context of, does a patient have this specific mutation? If they're MMR deficient, we know they're going to respond exceedingly well to immunotherapy. That PMMR population, we're still searching for something effective. So I think endometrial cancer and gynecologic cancer is kind of leading the way in terms of really narrowing down on the patient's specific tumor type and factors that make them responsive to therapy or not, and focusing on that as we move forward with other agents.
Yeah. And as we gain knowledge about this information and molecular profiling, what is your discussion in terms of layman's terms to your patients? How do you explain all of this to your patients?
Yeah, I'm thinking about when I'm sitting down with a pathology report, which always has their MMR, IHC, and I tell them, this is we do a lot of tests on your tumor to try to see if it has any mutations that make it responsive to certain therapy down the line, or a mutation that maybe impacts your family members, something that you would need to know about for other organ systems for you or people in your family. So I think I frame it broadly as just we're looking for mutations within the tumor, sometimes within you, that allow us to target your treatment specifically to you.
I think, the molecular classification, it has been for a while an NCCN guideline recommendation that all endometrial cancer patients get molecularly classified. And, just to kind of rehash for the audience, a lot of this data came from the TCGA many, many years ago. Well, we basically found there were several types of endometrial cancers that were prognostic. So there was POL-E, which is the ultra-mutated, and those were has excellent prognosis, despite what the histology is. You have P53, which is the most aggressive, the MMR deficient patients as well, and then you have the fourth class, kind of the bucket class, where we'll call the NSMP, where there's no specific molecular profile. And so, there's been this debate of whether, what's the utility of doing this, until recently when PORTEC 4A just came out, just got published in Lancet Oncology in January of 2026, where they looked at higher intermediate risk patients with uterine cancer. And they basically randomized these patients based on the molecular profile. And I think it showed some very provocative data and proved the hypothesis that molecular profiling can make actually a difference, because patients who were POL-E were randomized to either adjuvant brachytherapy because they were high intermediate risk versus observation, non-inferiority trial. It did not, and it met that criteria. P53 patients, they were randomized to either vaginal brachytherapy or external beam radiation therapy. And actually those patients who got external beam radiation therapy, which was the experimental arm, actually had better local regional control, because of the patients who got vaginal brachytherapy, despite being higher intermediate risk, stage 1, but since they were P53, they had a 30% risk even with vaginal brachytherapy. So that kind of shows that, yes, we de-escalate with POL-E, but with P53, maybe we should actually be escalating what we're doing. And of course, the intermediates were the MMR deficient patients. Those patients also were put to vaginal brachytherapy versus observation, and there was no difference as well. So I think this was the first randomized trial that's really kind of showed that, yes, I think molecular profiling is really going to make a big difference, in addition to histology, probably perhaps even better than histology on what we do for these patients, whether we escalate or de-escalate.
So it's really exciting, again, on the subject of de-escalation, that we have minimized the morbidity, the complications with the surgery. We have minimized the potential for additional complications with the traditional surgical staging with lymph node removal, now with sentinel lymph node mapping becoming a standard, and then now moving on to an additional phase of molecular profiling to be able to target what is the best treatment for our patients. So yes, really very, very exciting data coming out. I'll turn back to the topic of fertility and fertility preservation. As Beirut mentioned, of course, obviously, obesity is a major healthcare issue in the United States, and thus leading to the fact that it is now the most common gynecologic cancer for uterine cancers. This actually is leading to the fact that we're seeing a lot of young patients. In the past, endometrial cancer was a cancer of postmenopausal patients, typically. And now we are seeing patients in their 40s, 30s, sometimes even in their 20s with an endometrial cancer. So how do you go about your planning, your thinking, your counseling with your patients? And that young patient that comes in, she's never had children, she has endometrial cancer, and of course, obviously, ideally, she does not want a hysterectomy.
Right now, we don't have any, randomized control trials for fertility sparing management in endometrial cancer. We do extrapolate a lot from grade 1, which is a primarily indolent disease, hormone driven, and we know it responds very well, to hormone therapy primarily progestin treatment. So we do extrapolate a lot from those guidelines. And, I think it's really important to individualize the treatment. Like you said, talking to the patient, assessing what her goals are, what quality of life, all of that is very, very crucial, because right now, even with all the progestin therapies we have, yes, there's an excellent response rates that can put patients into remission, but the recurrence rates are still very high. So we know that disease will come back, and ultimately it's still not really recommended as standard of care. So however, with all that said, there are criteria that we look at. So, doing a proper biopsy, especially at diagnosis, doing a diagnostic hysteroscopy, there's conversations and data looking at benefits of actually removing any obvious tumor at that time to improve outcomes. And then discussing, getting an MRI to look for any true myometrial invasion. If it's all precancerous or grade 1, the response rates are that much better. There's some, gray area if it's a grade 2 with no myometrial invasion to still consider, hormonal treatments. Again, very individualized. But then we discuss, the options with, the levonorgestrel IUD, Megace, all of those options. And we always discuss that the treatments aren't necessarily easy, especially if we're looking at the oral progestins. I mean, if we're already considering the obesity issue, weight loss, infertility, PCOS, adding an oral progestin on top of that sometimes is detrimental to the goal that we're ultimately trying to achieve. So there's a lot to consider when counseling patients.
And as a follow-up to that, when you have a young patient, and you mentioned that the IUD is definitely a good, viable option for appropriate candidates, how often do you recommend checking to see if it's working?
Yeah, so the recommendations are anywhere from 3 to 6 months to repeat endometrial biopsy. And you want to make sure you get true tissue, not scant tissue. If there's a concern that they're having, any evidence of growth on imaging or symptomatic bleeding, you want to be a little bit more thorough. But anywhere from 3 to 6 months, you do want to make sure that there's at least some progestin response. No progression of disease, of course. And if that happens, of course, there's another conversation to be had that you're not responding to this regimen. But if they are responding at 3-6 months, you have a negative biopsy and they're desiring fertility, then that can be the next step for them with close observation.
And Carolina, when that patient has a full response, great. No evidence of any disease, no evidence of any pre-invasive disease, typically named hyperplasia. Mm-hmm. And they ask, when can I get pregnant?
So that's a great question. And there's not, standard of care guidelines for that. But, the recommendations are at least 1 negative biopsy. There's been conversations about 2. Sequential negative biopsies. And then even before all that, honestly, making sure that they have an OBGYN that they've already established care with. And most patients need fertility assistance. So setting up care, maybe sending a referral to the local fertility specialist, starting that workup. So as soon as they have that negative biopsy, they can start, looking at their fertility options.
Yeah. Some of my patients often ask, well, do I have a higher risk of the cancer coming back while I'm pregnant? What is your conversation with that patient?
Yeah, that's a very common question that patients have too. And, it is in general a very indolent disease. We do know that. So again, it's all about what is important to you. We are going to monitor you closely, see you right after you deliver, have a live birth, and repeat your biopsy, and at that time kind of readdress and see where we are.
One interesting question that came up for me, or a scenario that a colleague asked me about was, what if you have a 30-year-old patient, meets all the criteria, she's young, never been pregnant, has a grade 1, but she's Lymph positive? Would you still offer that patient, fertility sparing? I think.
Can you talk a little bit for our patients that may be listening as to what is Lymph positive?
Sure. So Lymph syndrome is a hereditary cancer syndrome where colon cancer and endometrial cancer are the most common types of cancer. Ovarian cancer also is high risk for these patients as well. And so for these patients, those are the primary kind of cancers that they're more susceptible to. And so, there's a question of, okay, would these patients be appropriate for fertility sparing, even if they meet all the criteria that the NCCN guidelines states? And if you actually look at the NCCN guidelines, they don't exclude Lynch patients. And so I think it's reasonable for a young patient who has all the criteria, for fertility sparing, that is really motivated and wants to get pregnant and will adhere to close follow-up to undergo still fertility sparing therapy as long as they meet the NCCN criteria.
Mm-hmm.
Really important point. I'm glad you brought that up. And Jess, I'll turn to you for that same patient population. When they have responded, they've responded very well. They were able to get pregnant. They have a baby. And they ask, now, can I have another baby? Or do I need to have a hysterectomy now because I had this history of endometrial cancer 2 years ago?
Yeah, these are some of the hardest conversations to have, I think, because when you have your oncologist hat on, you're like, I just want to get that uterus out as soon as possible. It's making me very uncomfortable. But, I think it's a little different in someone who's had cancer who hasn't, but the NCCN recommendation is at completion of childbearing, and so up to a certain age. And so I think going in the same vein as Behruz was talking about, in that patient who wanted another pregnancy, I think until they were ready to have a pregnancy, I would keep a progestin IUD in place. But I wouldn't take it off the table for someone who wanted more than one pregnancy.
Right. I agree. I would do the same as well. As long as they can adhere to close monitoring and good follow-ups, and while they're not actively trying to get pregnant, I would strongly recommend to keep that Mirena IUD.
Great. Before leaving this topic, Caroline, I'll turn back to you. There are patients who have been treated with IUD. The cancer is not getting worse, but it's not getting better either. Any options today? Do we have any recent data to add additional treatment to the IUD, add a hormonal therapy, anything else that could potentially help?
Yeah, so there is some data that's showing kind of dual progestin therapy can be more efficacious. So you can add on like oral progestins to the IUD and continue to monitor for a response. And then there's more and more data coming out about, GLP-1s and metformin, and how can we, again, try to improve the response rates to the progestin therapy.
Excellent. So, again, very, very comforting to hear that not all patients, young patients, need a hysterectomy, and it's very important for patients to have that discussion with their physicians, and for physicians to also understand that there's quite a number of young patients that can be treated conservatively without a hysterectomy. So I'll move on to the topic of adjuvant treatment, meaning treatment after having undergone a hysterectomy for those patients that have those higher risks of recurrent disease. Anything on the topic of de-escalation as it pertains to, are we de-escalating on radiation therapy options? You mentioned previously molecular profiling.
Right.
What do we have in the news?
Well, PORTEC 4A, I think recently is the most kind of recent de-escalation and also an escalation, if you look at the P53. Before that, there was PORTEC 2, right? GOG 99 and PORTEC 1 had external beam radiation for these high intermediate risk patients. And then PORTEC 2 came out showing basically equivalent outcomes, local regional control, and the morbidity of vaginal brachytherapy was much lower than external beam radiation. So the field moved and de-escalated more towards doing more of the vaginal brachytherapy, and now we're going towards this molecular profiling landscape where these patients with pol E may not need anything. And like I said, that based on this PORTEC-4A, that hypothesis is turning out to be pretty accurate. So, yeah, I think as we go along, and we'll see what the Rainbow trial shows too. And for our audience here, Rainbow trial is basically another trial looking at these subclasses of molecular profile and the randomization to see what the outcomes are as well based on the molecular profile. So we'll see how this continues to further evolve with using the molecular profile on de-escalation and escalation in some instances.
Great. Bruce, I'll stay with you on the topic of radiation therapy. And some patients will need radiation therapy, oftentimes for a prolonged period of time, 5-week regimen. For many of us, of course, obviously, we recall the severe complications from radiation therapy 20, 25 years ago. And certainly for many of our patients, that's a concern. When they hear you're going to need radiation therapy, of course, that brings on significant amount of concern and fear. Realizing you're not a radiation oncologist, but can you talk a little bit about, do we have any better tools today as it pertains to radiation therapy that can alleviate some of those concerns?
Well, first is, with the external beam whole pelvic radiation, we used to have what we would call the sledgehammer radiation, where we would just irradiate the entire pelvis. I mean, even before that, there was the abdominal, they would do the whole abdominal radiation, which was very toxic. But now they are using much smarter techniques, what's called IMRT, where the radiation oncologists with their physicists are able to kind of using 3D modeling map out where the radiation field is to avoid any of the kind of collateral damage that can be caused by radiation. So trying to avoid the bowel, trying to avoid the bladder. Obviously, de-escalating to vaginal brachytherapy also significantly helps as well, because the morbidity from external beam radiation is much less than I've seen based on my experience and published data. Patients don't have as much chronic diarrhea, issues with cystitis, or even the hemorrhagic cystitis. I remember fellowship, we used to do a little more. Again, also showing my gray hair here, I don't see that anymore, right? Because a lot of these patients are either getting very good IMRT or a lot of them are just getting vaginal brachytherapy.
Excellent. So, certainly, again, as you mentioned, and very glad you mentioned IMRT for the patients in our audience, is intensity modulated radiation therapy. And it's important to have that discussion with your physician as to whether that is an option for the patient, because certainly it is associated with less complications. So definitely, certainly much better options in terms of the radiotherapy. And Jess, I'll turn to you with regards to the patients who have advanced disease or the patients who have recurrent disease. Are we still treating with just chemotherapy? What are some of the newer options that potentially de-escalate on the toxicity of the treatments that we can offer to our patients?
Well, I think thinking about treating advanced stage endometrial cancer, many of them, there's the question of how do we combine chemotherapy and radiation. And with some of the newer studies that we have using immunotherapy in these advanced populations that didn't get radiation as part of the trial, and we're seeing good outcomes. So I think that's where we're starting to ask questions about who needs radiation. I do feel like in my time in training and as a GYN oncologist, it was kind of like everybody gets everything for advanced endometrial cancer. You're going to get either a PORTEC-3 or you're going to get 6 cycles of chemo and radiation. And we're seeing good data that might not be necessary for everyone.
And Carolina, I'll turn to you with regards to the discussions you have with the patients. Many times patients will hear us talk about targeted therapy or immunotherapy. What's your conversation as it pertains to that? And oftentimes they hear these terms and they think, well, am I part of an experimental trial, or is this now part of our standard treatment for patients with advanced or recurrent endometrial cancer?
Yeah, absolutely. No, we have great data now that shows the combination, especially for advanced stage disease, chemotherapy in combination with immunotherapy, whether it be Keytruda, dostarlimab for endometrial cancers, has shown much better response rates, progression-free survivals, overall survivals. The Ruby trial most recently came out for dostarlimab. So I think the molecular classification also comes into play here. So understanding what is their MMR status, that is something that should be tested up front, especially in the advanced stage setting, so we can tailor their treatments to give them the best response rates.
I think it'll be interesting. Right now they're not recruiting, but there's active a trial for DMMR patients where they're using Pembro alone versus the triplet therapy, and we'd be curious to see what that shows. Maybe we can de-escalate where these patients who are MMR deficient, they may need is just pembrolizumab, and no longer need chemotherapy.
One thing that I like that I've heard now from both Dr. Ramirez and Dr. Kowalski is when you're talking to patients and really emphasizing that this is standard of care, it's not experimental. I think that's very comforting, and I don't think it's something I've explicitly been saying, but I like hearing that and definitely going to use it going forward.
And I think also for our audience to know is, for these endometrial cancer patients, especially if they're P53 positive, the NCCN guidelines, have made a recent change where, they recognize that HER2 testing should be done on all P53 mutant tumors, not just the uterine serous or carcinosarcomas, which we have been doing, but for these patients, since there's such a poor prognosis, that HER2 positivity can also be seen in these non-serous or non-carcinosarcomas as well.
Yeah, absolutely.
So great options for our patients with endometrial cancer, and again, really encouraging results as we move forward in the treatment of this disease. And before we move on to the other topics and disease sites in gynecologic oncology, I'd love to hear from each of you as to why is it important to refer a patient to a gynecologic oncologist in a high volume center? What's the benefit to that patient?
Well, I think, there's ample amount of data showing that volume and expertise matters. And that is really just providing good patient care. So if a patient with gynecological cancer sees a physician or oncologist, it really benefits them to see a GYN oncologist who has high volume of these cancers, because they're very specialized. It's a very specialized field. It's a multidisciplinary field. We rely heavily on expert GYN pathologists, there are good papers showing that care, especially like an ovarian cancer, done by a GYN oncologist actually improves outcomes.
Excellent. Any other points that you would like to add?
I think it's also when somebody gets referred to me here at the Med Center, they're not just getting referred to me. I'm here with all of you guys, and I think that's a key benefit of being at an academic center is you're really getting the minds of many people working together and all have different ideas or have read a different study recently. And so it just creates an environment that's really beneficial for the patients.
Yeah, and I think the retrospective data looking back at, who is able to incorporate the latest recommendations when it comes to de-escalation, sentinel lymph node mapping, minimally invasive surgery, all of these techniques. If you look at it, it's not even the academic centers or the private practice hospitals. It's, those who have high volume. I mean, it's just something that is important to keep in mind,
Excellent.
to get the best care.
Great. So now we'll move on to the second most common type of gynecologic cancer, and I'll turn to you, Jess. Tell us a little bit about ovarian cancer, often called the silent cancer. What are some of the risk factors? What are some of the things that our patients should be looking out for as it pertains to ovarian cancer? And also a question frequently asked, is there a screening test for ovarian cancer?
Yeah, I do feel like there's a lot of similarities we'll have in this conversation, but it does feel distinctly different. Ovarian cancer is, to talk about ovarian cancer, it is the second most common. We talk about it as more rare, certainly, than endometrial and cervical cancer in the U.S. And it's hard because, to jump ahead to your last question, we don't have a good screening test. And where a lot of these de-escalation strategies focus on early stage cancer diagnoses, we don't run into that. And speaking in broad terms about high-grade serous ovarian cancer, we're not capturing a lot of patients in that early stage where we could study very well how do we de-escalate in this scenario. Just from a patient education standpoint, I have this conversation every time I talk to someone with ovarian cancer, and they're asking me, I don't know how this happened. I didn't feel sick. I had these very vague symptoms, and I tell them that's what I hear from everyone. It's very vague. We look for things like bloating, abdominal pain. Has your appetite changed? Do you feel like you're not able to eat as much? Is your belly swollen in a way that's not normal for you? But it's tough for patients who, these are older patients. Usually they've lived a life, they've been through a lot, they have a lot of symptoms that they minimize. And then it's important to educate the community as well, because they're usually presenting first to their primary care doctors. And so making sure that everyone is listening very carefully to the complaints that are coming in, even when they're very common or vague.
Yeah, I always tell I think that's important to emphasize for patients is that since some of the symptoms can be pretty vague, fortunately, this can be dismissed out in the community when they see their primary care doctors or they see a GI doctor. This is just heartburn or yada yada, whatever. So I think one thing I would emphasize with patients is your body, the symptoms that arise. So if something doesn't seem right, if you feel like someone's blowing you off, don't dismiss your gut. Go and get another opinion. Go see, ideally, an OBGYN, I think would be good in those kind of situations where they're a lot more kind of aware of this dilemma with ovarian cancer and the symptomology that comes with it.
Right. And Bruce, I wanted to ask you because, of course, obviously, we're going to talk about the typical ovarian cancer patient, which is the advanced stage disease and disseminated disease at the time of diagnosis, but you play an important role. You're a referral for many OBGYNs. What can you tell us about which patients can be safely managed by a general OBGYN and which patients should really be referred to you, particularly in that patient population where it is perhaps a young woman that presents with a mass in the ovary or a cyst in the ovary?
Right.
How do you triage that patient population and which patients should be sent to you?
That's a good question. I think when it comes to who are patients that an OBGYN can safely manage versus who should be referred, especially if a young patient, if they have an ovarian cyst, one thing a lot of the radiology departments are doing now is doing what's called the ORADs. And so they're basically classifying the risk factor of this possibly being a neoplasm or a malignancy, obviously 4 being the highest and 1 and 2 being more reassuring to be benign. I think getting tumor markers. So not only CA-125, but also CEA, in case it's a mucinous. Germ cell ovarian cancers, although rare, are another good tumor markers to get as well. So getting things like LDH, AFP, serum beta HCG. I think those are important things to do. And then what kind of symptoms are they having? If they're having pelvic pain, the ultrasound just shows a cyst. It's an ORADS 2. All the tumor markers are normal. I think very, very well suited to be taken care of by an OBGYN surgeon. The other question comes up is, I get referrals of patients who are premenopausal or, who have a cyst and their CA-125 is like mildly elevated, like, 50 or 60. And, the thing about CA-125 is it's not a very good diagnostic test for ovarian cancer. It can actually be elevated in a lot of benign reasons. And so, I'll talk to, then they'll ask me about the situation. The OB-GYNs will call me and say, is this something I should refer to you or not? And, there really isn't a specific cutoff, but I would say, look, if the ultrasound is reassuring, the CA-125 is mildly elevated, there's no other evidence of concern for ovarian cancer, especially if there's no family history or genetic syndrome like BRCA or BRCA. It's safe for you to do that. You can use, some people use a cutoff like anything over 500, sent to OBGYN, but things like endometriosis, I've seen women with 500 as well, and endometrioma. So that's one aspect that I commonly see. The other is postmenopausal bleeding with thickened endometrial stripe. That doesn't necessarily have to go to one oncologist. Sure, I'm more than happy to see those patients. And yes, they need some sort of biopsy. But an OBGYN can certainly do that as well. So It's just kind of a case by case basis. And I think those are kind of the most two common situations I run into where there's some ambiguity from the OB/GYN, what should I do here?
I was going to say, I think it's a little tricky there too, because sometimes you're on the phone with a benign gynecologist and you can just hear that there's some discomfort,
right,
or they're asking you to do it. And at that point, it's
right,
like, I want whoever's comfortable to
right,
operate on this patient. So in that case,
right,
send her my way.
And also, I see a lot of patients with benign conditions who, their OB/GYNs will refer to me because their surgery is going to be a lot more complex. And so, I think in that situation, if the patient doesn't feel comfortable or the surgeon doesn't feel comfortable doing a more complex, complicated surgery, they're probably doing the better thing to send it into a more advanced surgeon like a GYN oncologist to undergo that surgery. And in those situations, I'm more than happy to help.
Yeah.
So Jess, for many years, patients with advanced ovarian cancer went straight to what is called primary cytoreductive surgery. Not the case today.
Right.
Somewhat of a de-escalation concept as well. How are you deciding when a patient comes to you as a new patient who seems to have evidence of advanced ovarian cancer? Do I go to surgery or do I proceed with chemotherapy first and followed by surgery?
Yeah, anytime somebody comes to me with evidence of an advanced ovarian cancer, I'm asking myself the question of, do I think this patient would be better served by chemotherapy before surgery? It's hard to predict before you've been inside somebody's abdomen and you're trying to just go on a CT scan, but I think there are markers that we can use. So if I'm looking at a scan and talking to a patient and thinking that I'm going to be doing peritoneal stripping, diaphragm stripping, if they need a liver resection, if they're going to need a bowel resection and maybe an ostomy, that's someone I'm talking to about chemotherapy, because I think the de-escalation that comes with that in the surgery leads to some of those same, we're talking about patient-reported outcomes. Now, they're not waking up from an 8-hour surgery with an ostomy and having a 6-night hospital stay. We're getting them on chemo. They're having an interval cytoreductive surgery and back to chemo. So yeah, that's a long-winded way of answering your question, I think, but I'm considering it for anyone coming to me with what looks like a stage 3 ovarian cancer or higher.
What is your discussion with that patient that says, but just isn't surgery first better?
Yeah.
Shouldn't that be better? I mean, you're removing all of the disease. Isn't that how it's always been done traditionally?
Yeah, that's a very common question. I think for any cancer, patients have an idea that they want to just cut out immediately. And the way I approach that is, one, the goal of this surgery is to remove all of the cancer in your body. And if I don't do that at this surgery, then I haven't served you with the surgery. And so if I'm worried that right now we're not going to get to an optimal cytoreduction or an R0 cytoreduction, but I know I can use chemotherapy so that when we get to an interval cytoreduction, I leave that OR having left no cancer in your abdomen. That's the goal. That's what I'm trying to do. I want it so that there's no cancer in the belly when we leave. And when patients hear that you're thinking through how to make sure you get in there and get that surgery done properly, I think they're more like, okay, yeah, that sounds right.
Yeah, one of the things I also emphasize to my patients is that now we actually have 5 prospective randomized trials that basically show that chemotherapy followed by surgery, followed by additional chemotherapy, does not place you at a disadvantage compared to primary surgery. So very similar overall survival. So I think it's important to highlight that certainly, again, you may decrease the morbidity, the complications by doing chemotherapy first. And frankly, a trend that we're seeing across our country where there's an increase in patients undergoing chemotherapy first. Caroline, I'll turn to you with regards to the adjuvant treatment. Every patient with advanced ovarian cancer will require now additional treatment, sometimes called maintenance therapy. What are some of the options for those patients?
Yeah, so depending again on their molecular classification, whether they have any genetic hereditary mutations like BRCA1 or 2, if they're HRD, we tailor treatment based on the data we have and the response rates for maintenance therapy. So, PARP inhibitors are still, a great option, especially for HRD, BRCA positive patients. And then, it's actually, we're seeing it come more and more into the forefront of treatment. So with a GYO 036, we're, kind of combining it up front. So I think that this is a very exciting maintenance option, potentially something that will, be replacing chemotherapy potentially one day too. And then, if they don't have that, if they don't have HRD or BRCA, studies have shown that maintenance Avastin has also been a great maintenance treatment to decrease risks, shorten, prolong progression-free survival for that 15 cycles after they are in remission and completed upfront therapy.
Jess, I'll turn to you with regards to the patients that have a family member who had ovarian cancer or breast cancer. She's young, she's doing well, she's done with childbearing. They ask about prophylactic oophorectomy or prophylactic removal of the tubes and ovaries. What is your discussion with her?
Yeah, obviously I'm asking if there was any genetic testing done for these family members who had the ovarian or the breast cancer. Hopefully the answer is yes in today's day and age. If no, then that's something we need to talk about because we're seeing a signal there might be a pattern here and referring them to a genetic counselor to decide if genetic testing is appropriate. If testing has been done and there's not a mutation, I empathize with the patient. I understand can be anxiety-inducing and nerve-wracking, but to remove somebody's ovaries in a premenopausal patient, I talk about the bone, brain, and heart risks that come with that, and just offer my support that I'm here and I want to watch you very closely. And we talk again about the symptoms and speaking up for yourself. But in someone without a hereditary mutation, offering premenopausal BSO, even postmenopausal, we talk about risks and benefits of surgery. But it's just something I'm counseling on.
Great. And before leaving the topic of ovarian cancer, same question to you, Beirut. Any benefit to seeing a gynecologic oncologist rather than a surgical oncologist or potentially even a medical oncologist?
This is for
ovarian.
Well, again, going back to the data, the studies have shown that when a patient with ovarian cancer is seen by a high-volume gynecologic oncologist, their outcomes are going to be significantly better. Again, that goes back to the expertise that they have, the very specialization that our fellowship requires for this cancer, and it's shown in the literature that the outcomes are better. And so I think, for a patient with ovarian cancer, certainly they should see a G1 oncologist for their ovarian cancer care.
Excellent. So just to summarize on the topic of ovarian cancer, very promising that certainly we're de-escalating also in terms of the surgical approach to patients with early stage disease. We have better tools to determine which patients should be referred to a gynecologic oncologist, higher increase in the use of neoadjuvant chemotherapy and subsequently obviously decreasing the morbidity and the complications in our patients with advanced ovarian cancer, and then also options for maintenance therapy to improve the oncologic outcomes. So the third type of gynecologic cancer that we wanted to cover, of course, is cervical cancer. Not as prevalent in the United States, and of course, obviously, one of the more common cancer in women around the world. I'm going to focus on early stage cervical cancer, and there's been a lot in terms of de-escalation. I'll start with you, Beirut, and what are your perspective with regards to the greatest movement and findings in the last 5 years as it pertains to de-escalation in cervical cancer?
Yeah, I think, up there is going to be the SHAPE trial. That was a randomized trial that showed patients with stage 1A2 to 1B1 cancers who normally we used to do, a big radical hysterectomy with lymph node removal. Back in the day it was complete pelvic removal. We've now de-escalated that to sentinel lymph nodes to see that showing that can be just as safe and accurate. But in the SHAPE trial, basically, what we found was that in patients with certain favorable factors in their histology. So, for these patients, they undergo conization, and they are found to have, negative margins and, preferably no LVSI, with either a squamous cell carcinoma or adenocarcinoma that's grade 1 or grade 2, with obviously no evidence of extra cervical disease, extra uterine disease, that these patients can safely get just a simple hysterectomy with removal of sentinel lymph nodes, and have similar oncological outcomes with less morbidity as far as their patient outcomes.
Yeah. So this was an important trial. I agree with you that it took us from radical hysterectomy, a procedure that was associated with quite a high risk of potential complications, to just a simple hysterectomy as well. But important, as you mentioned, that this is for select patients, and there has to be a very thorough pathology, examination, and imaging to determine who is the ideal candidate for this procedure. Beyond that, for patients who are interested in future fertility. So, of course, obviously, cervical cancer is more common in that younger population. What is your discussion with that patient who is diagnosed with early cervical cancer, who wants to preserve her fertility?
Yeah, I think that's when conserve comes into play, which I think I've kind of put in the same bucket as SHAPE sometimes when I'm thinking about trials that de-escalate in cervix cancer. And so same thing in a very well-selected patient, low-risk patient. You can do conization alone with lymph node sampling, sentinel lymph nodes. And yeah, compared to thinking about the radical trachelectomies I've done for a similar outcome in the past, doing a cone and laparoscopic sentinel nodes, that's really de-escalated.
Absolutely. And when let's talk a little bit more about that, because obviously for patients who are interested in future fertility, one of the concerns that they have is, well, shouldn't I just have a hysterectomy? Wouldn't that be just better? And what is your discussions as it pertains to equivalence in terms of oncologic outcomes? Are they at a disadvantage? In other words, at a higher risk of recurrence by having a cone or having a trachelectomy?
Right. Well, I think, conserve is looking more specifically at cone. I don't think we have data directly comparing a cold knife cone to trachelectomy, but my counseling based on the conserve trial is that I'm not compromising your oncologic outcomes by offering you a conization alone versus a hysterectomy. We saw great oncologic outcomes in those patients.
Excellent. Carolina, I'll turn to you with regards to the lymph node evaluation. In endometrial cancer, we talked about sentinel lymph node mapping. Is sentinel lymph node mapping now standard also as a de-escalation in cervical cancer?
Yeah, absolutely. We have great data that also shows excellent detection rates for sentinel lymph node mapping in cervical cancer, and it also should be standard of care for surgical staging. The Sentinel trials 1, 2, 3 now are looking at the detection rates, in the 90s. So I don't think there should be any hesitation to feel very confident that you're not going to miss a positive node, again, with proper technique. And now most recently, the Phoenix study, is identifying radical hysterectomies with sentinel lymph node mapping versus just a complete pelvic lymphadenectomy with similar detection rates, and better outcomes for patients, less complications and morbidity. So I think if we, again, can proceed with sentinel lymph node mapping, we can not hurt oncological outcomes and still give patients even, better quality of life.
And Carolina, I want to follow up with you. Of course, obviously, we talked about endometrial, we talked about ovarian. This is cervical cancer. This is a completely preventable cancer. And oftentimes we talk about the fact that we shouldn't even be talking about management of cervical cancer, but rather prevention. And this is the greatest de-escalation potential, right?
Right.
Tell us a little bit about the impact of the cervical vaccine. How do we prevent pre-cancerous lesions? How do we prevent cancer in a patient that is potentially at risk?
Yeah, I think education is key, and I know some countries have reached, excellent utilization of the vaccine, and it's now, covered for, children as young as the age of 9. So starting education and awareness and getting the vaccine, injections at a youngest age prior to, any sexual intimacy will, again, prevent, the infection in the first place and causing the precancerous lesions on the cervix. But I think it's really important to provide that education, to even the pediatricians and the OBGYNs for some of these younger patients.
I think too, especially, here living in Houston, we have pockets in our city that have low vaccination uptake and high rates of cervical cancer. And so there's many different parties responsible for improving education and access to the vaccine in our communities to keep driving that rate down.
Right.
And just as a closing a summary, I also wanted to bring up the fact that, of course, obviously, we're practicing here at Houston Methodist. It is a conglomerate of a number of hospitals regionally throughout the city of Houston, particularly for you, Ruth, Carolina. Your thoughts on the level of care and the access to all of the topics that we have covered today as it pertains to coming to the medical center or actually having your treatment at the regional sites?
Well, yeah, the treatments that patients get at Willowbrook or Woodlands with Dr. Kalowski, similar to what they would get at the medical center. So the multidisciplinary care that we provide at Willowbrook and in the Woodlands, equivalent to what we do here. We work as a group together, right? And so we have a tumor board every week where we all meet once a week and we discuss our more challenging and more complicated cases. So we have that network set where, we're all kind of working together in partnership, taking care of the patients. And so, the patients are going to get their surgery. They're going to get their chemotherapy. They're going to get their radiation. And the nice thing is, if you live in Willowbrook or you live in the Woodlands, it's 10 minutes from your house. You don't have to drive an hour through that Houston traffic to get down here. So it becomes very convenient for the patients. Because, one thing patients need to understand is that cancer is not a one and done thing. You're going to see your oncologist, and you're going to see them a lot, probably for at least 5 years. And so, having that convenience, it can make a huge impact. And also, when you're in the hospital, if you're in the hospital somewhere where your friends or family are close by, it makes a world of difference for you as well. And so I think, for the patients out there, they should just be aware that, at Houston Methodist, the care that you get at Willowbrook or the Woodlands or the Met Center are very equivalent. Just do it based on who you like as far as the doctor and what's convenient for you.
Excellent. So, Carolina, anything you'd like to add?
Yeah, I think that's one of the main reasons why I actually was, happy to join the Methodist team, because we work as such an amazing cancer group. We focus on patient care and outcomes, but we're very research driven. We have clinical trials that we're open, and it's amazing that we work so hard to make sure that these clinical trials are also available at our regional sites. So, being PI on these trials in the regional sites and having patient, access, like Beirut said, 10 minutes from their door to these national trials, I think is a fantastic setup that we have here.
Excellent. So I want to thank each and every one of you, Dr. Carolina Kalowski at the Woodlands Methodist, Jessica Floyd here at Houston Methodist and Medical Center, and Beirut at Houston Methodist Willowbrook. This has been really a very fulfilling discussion, a very enlightening discussion, a great topic. And thank you for offering each of your thoughts on the de-escalation of patients with gynecological cancers. I want to thank all of you for being here. And again, very, very important for our community to have an understanding and an insight into the concept of de-escalation in all cancers for women and for our patients, to also be aware that there are many, many options that today offer better options for therapy, less complications, and then certainly much more innovative therapies. Thank you.